First of all, thank you so much for volunteering. This has been an overwhelmingly positive response to this opportunity, and I can't tell you how much I appreciate it. I anticipate a lot of our colleagues, as you'll see why in just a minute, are going to need our assistance. So really thank you. You will be doing this sort of between patients and off hours, phone contact with your colleagues throughout Nebraska Medicine and UNMC. So much appreciated. Our agenda is, first, a quick review of the HICS structure, to explain what that is. Then we'll talk about some of the unique challenges for healthcare workers in a pandemic. So you will have a heads up for what you are likely to be hearing as people reach out to you for help. We'll talk about some risk factors among healthcare workers in a pandemic for psychological distress. And then we'll do a brief review of Psych First Aid. I know everybody did the course and everybody did the refresher if they've previously done it, but just in case, we'll do a quick review of the primary objectives of PFA, what signs of trouble to look out for in the people with whom you're consulting, how to make referrals, dealing with anger in those folks, and then a brief touch point on how to track the contacts, that is, track the work that you're doing, and then a little bit on self-care. Okay, so HICS structure. So HICS stands for Hospital Incident Command Structure. Normally, when we have a disaster scenario, we set up a HICS structure. And usually it lasts like a day or two. So it could be, like we had a couple in the last few years. There was a power outage, there was a flood, there was one time where there was a weird smell and people didn't know what it was and they thought it could be a fire. They brought together an incident command structure and invoked sort of our disaster preparedness plan. Every year we drill something. It's usually an airplane crash, like at Epley Airfield, or some other hospital has some horrible situation. All their patients would have to be transferred to the area hospitals and we're going to get an influx. Those are the kinds of things we have always thought about in the HICS structure. And again, we stand it up for a couple of days. What's unique right now is we stood up the HICS structure a week or so ago, and it will stay open for weeks and weeks and weeks. So I've never been in an incident that lasted this long. But in a HICS structure, we have an incident commander, so somebody who's at the top of the chain, and then there are people who report to them. So like here, we'll have a public information officer. That's the person who handles all the media requests. A liaison officer, that's the person who does all of the work connecting with other hospitals and the Centers for Disease Control and nationally, internationally, people that we liaison with. And then the body of our clinical in-house response is here. So there are different sections, 4 main sections. The operations section is where most of the sort of medical care happens. There is a medical branch leader below, and then reporting to the medical branch leader, we have inpatient unit leader, outpatient, a casualty care unit, patient registration, etc. And one of the units is the mental health unit leader, or now called behavioral health unit leader. So that's us. So everything that we do is falling within this hospital incident command structure. So I serve as the mental health unit leader. If I should go down, then Jerry Walker would be the next in line, and Kim Bosek would be the next after me. So this is what we're doing. Our response and this PiNS program is all being wrapped up and rolled into the mental health unit structure within the hospital incident command. Okay, so what type of challenges are we anticipating with the folks who will be asking for help? First of all, concerns about proper use of personal protection equipment and infection control protocols. So these change, and throughout this event, we've had different PPE. Like in the beginning, everyone was on the biocontainment unit who was being treated, actively treated, and then they wore these PAPRs, these big positive air pressure, they look like moon helmets. Now they're not. They switched it at one point and said, well, just use the N95 respirators and the mask. What we're doing about testing of COVID patients is changing day to day. That is a source of stress for people. They learn one thing, they have to learn something else. Lack of organization and role clarity is a huge stress in these kinds of challenges. So you may or may not know that we started to treat the patients. We had people in quarantine and who had COVID in the quarantine center, but when they needed treatment, they came to the biocontainment unit. Well, about a week or so or two ago, we disbanded the unit as a separate unit, and then we combined it with the 7th floor. So they vacated the pediatric unit on the 7th floor, and they combined the biocontainment staff with other hospital staff, and they're now all serving together on the 7th floor for COVID patients. And then as we get more, this will expand out to other units. So it's tricky. They have their biocontainment unit manager. They've got their regular manager that they normally reported to. Sometimes people's roles are changing. You've seen the flex FTE information going out for people who may not be needed like in the procedural areas where they're canceling procedures, those staff may roll into other units. So difficulty with organization role clarity is another major source of stress for healthcare workers in a situation like that. There are changes in workflow and responsibility. I just mentioned a few in terms of the PPE and what people are doing, constant changes, and that stresses people out. I was working with the nurses in the biocontainment unit when the word first came down that they were going to combine with the other unit, and they were visibly stressed about how are we going to do that? We won't be with our usual team anymore. We're going to have a whole different workflow. We're not going to wear the PAPRs. So that's a source of stress. You would be living under a rock if you hadn't heard about supply shortages for personal protective equipment, most importantly N95 respirators and gowns, face shields. So that is stressing people out. We are now reusing our N95 respirators. You may or may not know, we came up with a procedure. We're the first hospital to do it, where we bring them to the old actual adult crisis unit and like hang them up on like a clothesline with the ultraviolet light that sterilizes them through the UV light, and then people will wear them again. So they used to be single use. That's now happening. But people are stressed by that. Altered standards of care and ethical challenges. So in a crisis, in a pandemic, where you have more patients than you can treat effectively, or using the existing resources, in particular, think about ventilators. So I'm sure you've heard about this strain that we are anticipating and hospitals throughout the country are anticipating, and some now experiencing. With a surge of critical patients, we will not have enough ventilators for patients who need them. So people with severely compromised lungs who need mechanical ventilation, and we'll have to start making decisions about who gets one and who doesn't. That is almost always traumatic for staff. Basically, we call that expectant triage. It's like this person is likely to die, this person may not. We're going to let that person die, and we're going to give the ventilator to the other person. Really difficult. And other kinds of standards of care that change when you have a surge in capacity bigger than what you can handle. We see this a lot when we're deployed out in the field. People who went to West Africa during Ebola had to handle that. We haven't really had to deal with that here in the United States that much, but it's called crisis standards of care also. But that's something that will be enormously stressful for people, and you will be receiving calls if we get to that point in our community, which we may very well get to. People are separated from their usual colleagues, so people are working on units they didn't work on before. That's what the biocontainment unit is, by the way. Most of the time, we're not deployed. These people work on other units, and they come together, and they work there. So that's a stress for people. Witnessing the death of patients is another stress. In particular, the literature shows that healthcare workers are particularly stressed by pediatric death. And, of course, we hope that won't happen, and we're hearing that this affects older adults more than younger adults, but any death of a patient is stressful, particularly when you feel like you're helpless and you can't give them what they need to support them. And we know from research on healthcare workers responding to the SARS and Ebola epidemics that illness and death in colleagues is particularly challenging and often traumatic. There are challenging team dynamics you might be hearing about, right? So these are teams that are stretched. If this pandemic sweeps through our community, we could have 30–40% of our healthcare workers out. So the remaining out because they're testing positive or they're sick. So the remaining team is left caring for these patients. And that creates all kinds of challenges and strain. And sometimes people have challenges with one another, let alone the moving around of people. As I mentioned before, I gave two examples of that, the biocontainment unit team merging with existing units. And I also gave the example of the flex float pool. So you might have a procedural person who all they ever do is endoscopies. Now they're working on another unit, and that's a source of stress. Of course, people are afraid of contracting the illness. They may be afraid for their families. So they may say, well, I'm fine, but I live with an elderly person or someone with a compromised immune system, someone being treated for cancer. And so there are those concerns that our staff might have. People may feel misunderstood and have to justify their work commitment. So their family members may say, what are you doing? Just call out sick. Just get another job. Don't do this anymore. And they have to, in addition to suffering through all these challenges, try to justify, well, this is my commitment. This is my calling. I have to do it, to people around them who may be asking them not to do it. Then when we decommission units, there's stress with reentry to regular units. Even if people are happy to go back, these transitions are always stressful. There's also the issue of stigma and lack of appreciation. So in working in the quarantine unit in the past month, I've talked to staff who have been told that they can't attend family functions, This was before social distancing was asked, across the board. So because, they might bring something to the function. I've had staff who've told me that their spouses, employers, told them not to report to work from home, because they were concerned about exposure from their spouse who did not have COVID-19 and who was wearing all the personal protection equipment and doing everything right. And so there's certain stigma that can happen around being tested positive or about just being exposed to the virus, even if you're not positive. There's fatigue and limited rest time. So a lot of people are working extra shifts. Again, think about 30 to 40% of our workforce being out. You know that people are going to work lots of overtime. Personal and team pressure to succeed in the care of patients, another big source of stress. We are looked at as a national leader here at Nebraska Medicine. If you're not aware, we are, training the rest of the country and the world in biocontainment procedures and donning and doffing PPE. Even in our wellness and resilience, we've gotten requests from across the country for what we're doing and how we support our staff. So there's a pressure to do well and to succeed at Nebraska Medicine, and not just our own pressure, but also from the team. So that's another source of stress. And finally, a lot of our healthcare workers, they may not want to admit it, but they have a certain amount of doubt, just self-doubt about all these changes and procedures and everything else going on. So this slide I spent the most time, the rest is going to go quickly, but I felt it was essential for all of you who may be supporting our colleagues to understand a little bit about the kinds of things you may be hearing, so that when you hear them, you can anticipate and you can act knowledgeable like you understand. Okay, so a couple more points about psychological stress. What we know is that the more of those challenges we just saw, and by the way, even though those seem really timely, that all comes from our research with SARS and Ebola that we did with healthcare workers in the past, and they seem perfectly relevant today. So the more of those challenges that there are, the increased distress our healthcare workers will experience. Now, most of our team here will be resilient and won't experience lasting distress. But we know, and this is based on research with disaster responders, that about 10 to 20% of first responders and healthcare workers are at risk for a new disorder that they didn't have before the event. So these are things like post-traumatic stress, insomnia, alcohol and drug misuse, depression, and anxiety. And it's important for you to know, as this unfolds, that symptoms can appear after the outbreak is under control. So people may do okay, they kind of become resilient, they shore up, they become heroic, they do everything they need to do, and then after, when things come down, they begin to have symptoms. Not unusual. Symptoms do decrease over time, but we may see relapses, especially if there are pre-existing mental health conditions and with re-exposure to additional infectious disease outbreaks. So I just want to highlight 4 risk factors in particular. There are many in the literature for psychological distress for first responders and these kinds of infectious disease outbreaks. 4 in particular you should be aware of. One is a perception of heightened risk for infection. When healthcare workers feel like they're at greater risk, then they're more likely to experience post-traumatic stress symptoms afterwards. The longer the duration of the high-risk exposure, the greater the psychological risk. If there's a previous history of psychiatric illness, now I know, and we'll review the psych first aid model in a minute, we're not doing diagnostic evaluation in this peers in need of support program, right? You're being a supportive person, but you're listening with your clinical hat, and so you're not going to take a whole psych history, but be aware that if there is a previous history of psych illness, and people often offer that up, that is a risk factor for increased distress. And critically, a lack of social support is another risk factor. Okay, phases of a disaster. I don't know if people have seen this before, but this is kind of a famous behavioral health, disaster behavioral health graph. So typically, and this is kind of based on your tornado, your hurricane, in the immediate aftermath, right after impact, there's this phase here where people rally, they support each other, they're heroic. It's kind of this honeymoon phase, we pull together, Nebraska strong, Boston strong. And it's a feel-good kind of like rallying moment. But what typically happens, which you don't hear about in the news afterwards, is this. And so when FEMA doesn't deliver the aid right away, when people can't get their houses fixed up right away, when they've been living at a hotel now and it's going on the 6th week, you get the disillusionment phase. And that is often expressed in anger at authority figures. Why aren't people helping us? And you inevitably see this. And then finally, you see here this reconstruction and rebuilding, and afterwards people finally get back to normal. Why this is so important is this is really unprecedented in my experience in disaster behavior health and working in infectious disease outbreaks. the length of time this could go on. I mean, it's been going on. We've been hearing about it. It's just like this slow rumble. We're sort of sitting here waiting for this to come through and expecting it to get worse. And so this phase could last a really long time. Those of us who were involved in the initial deployment with the Diamond Princess folks, we've been doing this for a month already, you know? So those folks and the nurses on the biocontainment unit, they've been working extra shifts already for a month. And this could go on for 8 more weeks. It could go on, who knows? So I just mentioned that so you're sensitive to the fact that anger, disappointment, disillusionment, I suspect we'll be seeing some of that for an extended period of time, because unlike a tornado, which happens in a day and people rally, and then you see this could just go on for a while. So keep that in mind as you're working with our folks. All right. I expect everyone did either the online psych first aid course, did an in-person course. We set up a few courses a couple years ago here, or if you've done it before, you did the refresher. Jerry's keeping track, Jerry Walker, of who's done what. We really only want to deploy the people who have done the training, so he'll probably be reaching out to people who've done it. But very briefly, what are the primary objectives of psych first aid? It's to take someone's emotional temperature, right? You just want to see how they're doing, figure out what's going on. Your goal is to bring them down from like an 8, 9, 10 to a 6 or 7. Don't expect to get them down to a 0 to 4, right? It's not reasonable and realistic. Our idea is just to get them calm enough to kind of talk with them, give them some resources, talk about solutions. I'll go through the other pieces of this. But what you want to do is get people down from really, really hot down to, you know, sort of hot. If you can do better than that, great, but it's not realistic to expect in a brief phone call that's going to happen. In psych first aid, we want to encourage people to take some kind of action, to do something to improve their well-being. So you want to make it action-oriented. We don't want them depending on us to do something to them. This is not, you know, like long-term psychotherapy. So we encourage self-reliance in psych first aid. You want to convey that they are not alone, that other people are going through it. Misery does, in fact, love company. And you want to provide information on common reactions to stress. People think they're going nuts. They've never been under this kind of stress. They can't, you know, why can't I concentrate? I'm having these, you know, nightmares. I'm having these experiences. I'm so irritable. Like they don't recognize themselves sometimes. And so you want to make sure, if it in fact is true, and we'll go over what are common reactions, that no, these are common, you know, these are normal reactions to abnormal circumstances. I'm sure you've heard that before, and this is a time where you would use that, right? So we convey their reactions are normal. So what are normal reactions to stress? So I group them in these 4 categories: physical reactions, muscle tension, stomach ache, headache, right? We all know what ours are. You should be aware, you know, we get fatigued. Emotional reactions, so everybody has their kind of go-to emotions. Some people become fearful and anxious rather quickly. Other people get angry. Some people kind of resign into hopelessness or guilt. Then there are cognitive reactions to stress: trouble concentrating, trouble remembering things, feeling confused, catastrophizing. And finally, behavioral, right? And you know who you are here. Are you the person who starts snapping at other people when you're stressed? Are you this guy here overworking? Are you somebody who becomes, impulsive when you're under stress? Do you withdraw and isolate yourself? Poor self-care, use drugs or alcohol more than usual. So these are things that we expect. These are fairly common reactions. It's good for you to be familiar with them. So when you're working with our frontline staff, you can say, up, common reactions. So what should be worrying? When should you make a referral? When is it something that's more than just typical reactions? One would be ongoing intrusions. You know, so it's not just a day or two, but it's lasting several days or a week or two. So this is where the traumatic or upsetting material comes back to consciousness in some form, either a nightmare or a flashback where you feel you're actually back in the situation, or just intrusive thoughts that prevent you from concentrating. Ongoing hyperarousal, so, you know, high anxiety that won't remit, insomnia, irritability, you know, from the PTSD criteria, that exaggerated startle response. So someone's sympathetic nervous system is amped up and they just can't bring it down. That's a sign of maybe referral. People avoiding reminders of a traumatic event. You know, they're not going to work now because they just can't go back on that unit again, right? That's an example of something that would warrant treatment. They're avoiding feelings by using substances. They report feeling numb, spaced out, like things aren't real. Again, some of that in the immediate aftermath, but if that's been going on for 2 weeks, that might be something to trigger a referral. And of course, when daily functioning is affected. So when people can't do their normal home responsibilities or can't do their normal work responsibilities, that's the time to consider making a referral. When you make a referral, be cautious, right? People can interpret that as stigma, like, what are you saying? I'm crazy? Why are you telling me to see a shrink? So you want to very carefully explain the reasons and respectfully, you talk about, these are common reactions. We do have some really good techniques that can help people. Lots of folks will just, see a counselor for, like a coach, help you work through this. So you want to be cautious as you make these referrals. Sometimes I mentioned before about the disillusionment phase, right? And also about people's different stress reactions. You deal with angry people, especially if, there is a shortage of PPE, right? Like, why aren't our leaders protecting us? Why are they making me go into a room with a N95 respirator that I had to wear all day and then disinfect with ultraviolet light in this new procedure? Where is it written that that's going to protect me? So people may be angry and feel like they're not being taken care of. You want to stay non-defensive. You want to begin with a statement of empathy. This is basic PFA stuff, right? It's nice to meet you. I'm sorry it's under these circumstances. Focus on what they can do, not what they can't. So if somebody's, this my epic just ended. Focus on what they can do and not what they can't do. So if someone is, I'm going to tell my manager this, rather than saying, well, you can't, just say, well, one thing you could do is you could reach out to this person, or have you thought about sending a letter here? Or maybe, so it's just like with kids, right? For those of you who work with kids, rather than having a set of rules that are don't scream and don't run in the house, it's use your inside voice, walk in the house. In the same way, we want to focus on things that people can do, not what they can do. Of course, you want to show respect to people as you're interacting with them. And this is an interesting PFA suggestion. We're trained to ask open-ended questions. So tell me how you're doing, or, what have you thought of? But when people are upset and angry, sometimes it helps to just switch over temporarily to close-ended questions. Well, have you done this? Have you thought about doing that? People can just say yes or no. It sometimes brings down the temperature. It's easier for them to concentrate. You're sort of lending them your frontal lobe for the moment by sort of thinking through some things, and they can just say yes or no to. And then as they calm down, you can go back to your open-ended questions. I just want to also mention about self-care. This is a little like parallel process, because these are things you can also be sharing with the folks you're working with. But you want to find someone with whom to debrief. This is, it could get tough. The more of these stories you hear, or you just might hear a very difficult story. So it's always goes back to social support, but you might want to link up with somebody. There's a lot of people, and their names are all on that spreadsheet Jerry was talking about. So also connect with your social supports if this gets tough for you. Again, can't emphasize that enough. The literature could not be more clear that that is one of the most important elements of resilience. Use your stress management techniques. Use the stuff we teach. Use your mindfulness, your deep breathing, your body scan. Limit your media consumption. Keep a gratitude journal. One of my favorite interventions. Exercise, eat well, get sufficient sleep, spend time outdoors, right? These are basic self-care tips. So I'm just reminding you as we get sucked in to this process, because this is going to be a tough slog for all of us. Take care of yourself. Reach out to one another for support.